accounting before switching gears to this wonderful profession of occupational therapy. And really, there's one thing I can tell about myself. I love data. So I'd like to share our story of working with data with Jim at Rush. When I initially connected with Jim's department almost a year ago on a volunteering basis, Jim had this big pile of data that he just presented on the other slide. It was unorganized.
What?
We
would have hearted that.
started to organize it a little better, and we were able to answer some questions, some interesting questions. For example, what is the gender distribution of your population? So in the simplest form, for the years of 2015 and 2016 so far, there were 111 men and 211 women that were treated in his clinic. If we wanted to get a little fancier, we could look at the so-called age pyramid, which presents the information, the gender distribution by age brackets. Females in purple, men in blue. We can also take the same information and look at it this way. So we can tell that most males that came to the clinic were in their 50s. First two bars denote that. If we wanted to take a look at the number of women, we can see that most of them are in their early 40s and early 30s.
Now, I want to pause just for a minute and point out something that's interesting. We don't have enough data to make any conclusion out of this. You know, we have 300. But if we had 300,000 pieces of data, and I started to notice that women show up at the hospital 40, 30, 20, there's one outlier here where it's 25, I might start to wonder, what happens with women when they turn the next 10 years that might increase stressors, might make them more vulnerable in those first few years to being hospitalized? Big data could start to be really interesting. It might start to ask questions or get us to ponder, like, what's going on there? And sort of kick off or drive us toward what would be interesting research.
I tell you, it's children.
It's children, it's men, it's oh my God, I'm 40. And this is not the story I had for myself when I was 40.
And they hit menopause at the same time their kids start their hormonal raging.
Notice we have some research, speculative designs starting in people's heads. I wonder. And like I said, with 300 people, this could just be a total anomaly. With 300,000 people, it's kind of interesting. What's going on here?
So what else can we tell about our clients? How do we know who's walking through our door? We can see that most of the clients here have depression, then anxiety, then addiction, and so forth. If you have a population with mixed diagnosis, we could probably pick out what's the most common one for the past week or 2 or 3. But if you wanted to take a look at this for the whole year or for 2 years, it might be a little difficult. Here's something interesting. This is a useful adaptation of the COPM measure. And you have the cards on your...
So when we did the card sort, right, this is where we're getting that information. When people sort out, these are the things I most want to work on. What are we ending up with?
So when they look at the 12 options and they make their choices, then you can ask yourself, what do they want mostly? And then you can tell it's not the community management. It's their rehab, it's their self-care, daily routine, and their friends.
So that's true in my clinic, but your clinic might be very, very different. Probably is, right? But I have live ongoing data about what do they want, what tools do I design. If I'm trying to create an intervention that has meaning for my clients, which ones do I design? I can look that up week to week. Right now, that's what people want.
We can say more than who our clients are. We can ask ourselves, are we achieving the outcomes we want to achieve? So we're wondering if there's a way we can quickly and easily see how many of the clients are making an improvement, or are they making an improvement at all? So this is called the AAQ. It's on your handout again, and it's an assessment that measures psychological flexibility and experiential avoidance.
Anybody who's familiar with acceptance and commitment therapy, this is a tool that is very widely used. It's an open source tool. It has good reliability and validity. It is 7 questions rated on a 7-point scale. It measures change with very little bit of change will show up on this, so it's a very sensitive tool. And it's a very quick tool to administer. We can do this pre and post on somebody's, they're about to leave the hospital and they got a couple minutes, they can do this. It's not a big deal. So a lot of our interventions are primarily aimed at changing psychological flexibility. So the question really is that happening? And this may not be what I'm doing in group, although that's what I'm aiming at in group. This may be the environment that they're in, the fact that they're in a hospital, they've gotten medications. There's a lot of factors that might be doing this. But the question ultimately for the client is it happening? Blue is people who improved, red is people whose scores have gone down, and green is no change.
So similarly, we can do the same thing with general rating of function, which measures the client perception of function. So this is the data from the same clients that we presented earlier in the age distribution, and it looks like most of these clients perceive their function to be better at the end of their stay. And I think we're going to talk about CET next.
Yep. So we can use data in a different way though too. You can use it to sort of say, am I doing what I'm hoping to do? But you can also use data if it's flexible enough to tell you what should I do next. So we have a form that asks these 5 questions of clients. I often give them just sort of randomly throughout their stay after I do a group intervention. You could also do an individual intervention and use this. So it says things like, my therapist is present, responsive, and non-judgmental. I feel understood, accepted, and respected. The intervention seems meaningful and helpful. The therapist approach is a good fit for me, and my overall rating of how that session went was on a 1 to 10 scale, okay? I calculate that by scoring the percentage that comes out of that. It's a 5-point scale, so that makes calculating percentage really handy, easy. I just add it up and double it. There we go. And if somebody drops below 70% on that, what it tells me is I should go have a conversation with that person. Or if somebody scores really low on I feel understood, accepted, and respected, I should probably have a conversation with that person. And that intervention has oftentimes been very simple. It's been me going to the client and saying, hey, you gave me some of this feedback, and I just want to know, what is it that makes you feel misunderstood? What did I do? What could I do better? I'm really interested in this. And in many cases, my clients have not given me a specific answer of how I could change that, but just because I asked, it changed. Oh, he cares. I've had clients say that to me pretty directly. In terms of long-term scoring, this is where I'm at right now. I don't know, can you guys see the numbers underneath? So most of what I have is above 80%. The other thing that this tells me, I think, is that the intervention that I'm using works for clients. In general, their overall perception is that